Welcome to this special edition of HorseCity.com TV. I'm General Manager Ryan Dorn here with my friend and also our resident vet on Horse City, Dr. Mike Lauder, also here at the UGA, University of Georgia College of Veterinary Medicine. Dr. Mike, tell us some of the things that you typically see referred from vets all across the state.
Well, we see things actually from all across the southeast, and one of our most common things is colic and lameness. Tons of lameness come in here because we've got some of the unique equipment to help us diagnose some of these horses that come in for performance problems. So one of the things we're going to do today is we've got a horse that's been presented that's got a history of a performance problem, and we're going to see if we can isolate that. When we look back here at our patient, he's going to be sent in today for a performance problem. And one of the things we commonly do after we get these horses and we go through a lameness test with them is we're going to take them to radiology. Okay. And radiology is such an important thing because we're trying to isolate very small problems in an animal's joint and see if we can come up with a diagnosis here.
Well, that's great. Well, we really appreciate the University of Georgia College of Veterinary Medicine letting us in for a sneak peek at this entire process. So let's head off to radiology.
Excellent. Let's go.
All right, Dr. Mike, our first chance to meet Corey, our AQHA gelding here in the UGA radiology suite. So tell us a little bit more of what we're doing here in this room.
Well, Ryan, what we've got is we've got a performance horse here that's done well in the past. He's really taken his riders up to that next level. Well, recently he's had a decrease in performance. He slowed down just a few seconds, and seconds mind everything when you're starting a performance horse. He's had some swelling in his joint after the performance. So what we're going to do today is try to isolate why he has a swelling in his knee joint. And one of the ways we do this is start taking some x-rays. It's one of the basic things. This is a horse that's referred up by one of the local practitioners in the state, and they send him up here for some extra diagnostics, things that we can do that may not be able to be done in the field. So that's what we're going to do today. We're going to see if we can find out what our problem is with Corey.
That's great. Well, let's step out of the way and let them
let's get out of the room where they can do what they're doing. Thank you. What they're going to do is Rebecca over here on the other side is going to bring this film in behind, and she's going to stick this cassette up close to that joint. Charlene on the front is bringing that x-ray unit in straight in.
And Dr. Mike, how many x-rays, pictures for layman's terms are they going to take?
She's going to take 5 views. And they're going to take 5 views to show all the different angles of this joint. They'll do a flex joint, they'll do the obliques, they'll do a view straight from the front and one from the side. And what they're trying to do is pick up any small changes, any minute changes in that joint that may cause this horse to have a decreased performance.
So we'll take these pictures, and then next stop will be for us to take a look at them up on the light board.
That's right. We'll get on the light board and we'll see what we can find and see if we got a problem. What we're doing here today, Ryan, is trying to look at these x-rays and see if they can pick up where we're having this performance problems. And if you look right here, this flex view here, and this is an angle view of the carpus, it shows that we've got an osteophyte, a little chip sitting right here where this joint flexes. And what this does is interferes with the horse when he's flexing his joint as the tendons cross across the front part of this joint here.
So this is the radiograph that shows the knee flexed, then fully flexed.
This is the radiograph that shows the knee fully flexed. It's from an angle. This is an oblique view. And this is picking up this problem we have in the joint here that's going to at least show us what our diagnosis is. We've got an osteophyte. We've got a little bit of...
Something that small, Dr. Mike, can make that big of a difference.
Oh, yes. It doesn't take much. It's the size of a pinhead sometimes. And you'll be surprised when we look at this and get it out how small it really is.
So what is this other view over here to the left? What is that showing us?
This other view over here to the left is another oblique view of the leg standing, the horse standing on it. And you can see this chip sitting right out here to the side.
Now, what does oblique mean again?
Oblique means they're coming off at an angle and trying, like a 45-degree angle, trying to pick these things off, because sometimes if we come back over here to this other view, when you look at this view here, it's a straight lateral. You don't see our chip at all. You don't see our osteophyte. And this is the importance of getting all of the views when you're trying to have a horse diagnosed for lameness, because sometimes one view doesn't show the entire story.
So our patient that came up, or the customer that came up, it looks like the referral from the vet, they were right. Something's wrong.
Yes, the referring vet did a great job. He isolated the problem to that carpus, and he knows there's something there. And with the x-rays today, showed us what we've got to do, and we're going to have to go in there and clean this joint up.
So I guess our next step, Dr. Mike, is to go ahead and get Corey ready for surgery.
It sure is. Our next step is to get him into surgery and get that joint open up where we can see if we can find this problem and remove it from the horse. What we have is Dr. Adams is going to just wash off some of the initial shavings and things like that that are on the feet of the horse. Now what we're doing now is we're going to put the horse up into the corner here. They'll pull this side door around, and that'll allow them, when they induce him, just to slowly slide down and protect the horse as best we can from hurting himself when he lays down. A 1,000-pound horse is a lot of weight to hit the ground.
Sure.
All right, now what they're going to do now is they're going to give him the induction anesthetics, and that's going to cause the horse just to go to sleep, and he'll slowly ease down and go to sleep here and just slide down against that wall. Now what we're going to do is Dr. Adams, she's going to have the horse intubated, and this is going to ensure that he's got adequate airflow during the entire surgical procedure. The tube in place. They'll go ahead and we're going to relax the door, let the horse lay down.
Or you can let it all the way open.
Now what we're ensuring now is the anesthesiologists are making sure that he has enough oxygen flowing to him in this transition period from going from the recovery stall to the surgical table. What they're doing there is they're covering the legs of the horse with plastic sleeves to make sure that any small particles of manure or shavings that wasn't washed away won't fall into the surgical area. So they're just going to cover his legs, and the next thing they're going to do is Dr. Adams will have these hobbles placed upon the horse's leg. There'll be one on each leg. They're going to bring this crane around, this hoist, and they're going to hoist the horse up, and then they'll roll him into the surgery suite and place him on the table in there. Now what Dr. Adams is doing, one of the anesthesiologists here at the University of Georgia, we're going to raise the horse up, and then they'll take him and they're going to pull him into the surgery room and place him on the surgery table. There you go, to right there.
Okay. Hang on forward. That's good.
Back up and turn it to a little one shot.
Hold it flat. There you go.
Excellent. Excellent. What Dr. Eggleston is doing now, he's placing a bunch of initial drapes, these big blue gowns that we see, and the purpose of those is to protect the surgical field. They're to keep any dirt or debris that might shift up from the horse's hair as the surgery is occurring, to keep the surgical field from being contaminated. They'll place several drapes around the horse, and then when we get everything draped in, then he'll get ready to start the actual surgery.
Can you tell us a little bit more about the respiration system that the horse is on?
The horse right here is on a ventilation system, and they're actually breathing for the horse. They're forcing the horse to breathe, and you can hear that sound in the background, and that is the oxygen being pushed into the horse's lungs, and then he's expiring. The anesthesiologists are monitoring his heart rate, his blood pressure, all the things that happen when we go to surgery. His body temperature is being kept at a certain level. If you notice over here at the back of the horse on the ground, there's a machine that's blowing warm air into a big thick blanket all the way around the horse to keep his body temperature elevated, because the surgery rooms are usually a little bit cool, and that's to help the people when they're gowned up from getting too hot as they're working.
So they really take a lot of great care to prep in advance for the surgery.
There's a lot of care, a lot of forethought goes into this. It's a huge team effort, and what they'll continue to do is to try to protect the horse, protect the leg, and make him as comfortable as can be, because the surgery, the true success of this surgery is going to be the horse getting up, standing up, walking back to the stall, and a few months down the road, somebody riding him back in the show ring. That's where we want to be. What Dr. Eggleston is doing is getting some tubing ready that when they start working into the joint, they're going to be pushing warm fluid in there to try to keep that joint hydrated and distended where you can see what he's doing. So all this fluid that's been coming through this tubing is being heated to body temperature, and he's going to, once he gets his arthroscope into the joint itself, this warm fluid will be flushing that joint as he's working, because there'll be blood in there, and he's got to keep it clean and clear where he can see what he's doing.
So how is this similar to something that an athlete, a human athlete, would have done?
Same type of surgery, same exact equipment, same thing that's used on people.
Other than getting hoisted by the 1-ton lift.
Right. Other than getting hoisted by the 1-ton lift, it's the exact same equipment, same training, everything. We just have to take a little bit more precaution because our patients are a little bit bigger.
And Dr. Mike, how many of these type of surgeries are performed here at UG? Maybe it's better to ask maybe on a monthly type basis, or
on a monthly basis, they probably do about a dozen of these a month, and it just changes with it, what they see. This is obviously classified as one of the orthopedic procedures, but Dr. Eggleston and the other surgeons here will do probably a dozen orthopedic surgeries a month, if not more than that. And again, colic being the predominant surgery that occurs to us, because we're the only place in the state of Georgia that's set up to handle colic surgeries. And it allows the university, good exposure, and it's good for the people of the great state of Georgia to have a place to refer their horses to get a type of attention that they can't have in most cases in their local county.
Now, we should let people know that this is rare. The University of Georgia allowing us to come into a surgical environment like this is just not something that happens. So we're, very thankful. And we need to let people know this is a very rare occasion for them to see something like this up close and personal.
It really is. This is the first time I think we've had cameras in the surgical suite other than for teaching purposes. And what we're trying to do here is show the level of care that a patient can have and how much attention is given to this horse's performance, because there's an owner out there where this horse means everything to. In order to get that horse back in the performance ring and performing at its best, this is the type of care it needs. And horses this day and time are at the next level. They're faster, they're bigger, they're better than they were 10, 15 years ago. And as with any athlete, you develop problems over time. And this is going to continue this horse's useful performance lifespan where he can continue to do what he likes. Horses enjoy performing. They're just like people. They like to get up and go and run and have fun just like the rest of us.
This needs to go in his. Dr. Mike, tell us what we're seeing a little bit on the monitor there.
What we're doing now, Dr. Eggleston's introduced his camera port, and there's being fluid injected into the joint and extending it. And you'll see a few air bubbles floating around. There's one right there. You'll see them floating around through there. And that's just air coming through the line. And he's trying to look through and see if he can isolate the areas of pathology in this joint.
And so what we saw in the radiographs, he's looking for that now in real life.
He's trying to correlate the radiographic findings with what he's seeing in real life here.
When there is loose fragments or foreign bodies in a joint, what that joint wants to do is grab that, get it out of the joint so it doesn't float around and cause, you can imagine if you were to throw a pebble in between these two surfaces right here, or between these two, throw something in that joint. When this leg now straightened, you would do a significant amount of damage to the cartilage. And so the body's response is to grab those pieces, get them out of circulation, and actually hold them so they can't move around. And that's exactly what happened to that fragment. What this is just a mechanical burr. We call it an Arthur burr. Has several attachments. One that you can actually debride or clean up the cartilage in the underlying bone. This one is a synovial resector, basically a lawnmower. All I'm doing is trying to speed the process up. Some of this tissue that there's a fair amount that I'd like to get out of here. This just helps me out to do it a little bit quicker. You have to be really careful with these because you can do a fair amount of harm if you let it get out of control and go too deep on the tissues. So I won't do too much with it. I'm just trying to get some of this out of my way initially so I can see the rest of the joint and then pretty much finish up. We don't have too much more that we need to do to this joint. This is just abnormal cartilage that is, all this fuzzy appearance is abnormal. It's cartilage that has been broken down due to, one, that bone fragment that was in the joint, the inflammation and other changes that have been going on in the joint. And so it's not doing anything of any significance to help support that joint. So we'll remove most of the loose tags. You can see the edge of it where it meets with the more yellow tissue, that's bone, and all of this white tissue is cartilage. You can see along the edge it is still attached, so I don't want to go back any further, and I'm just lightly cleaning this margin up. Unfortunately, the portion of the bone right here, if you look at it, this surface and this surface are the two that make contact, and so although this is quite pitted and abnormal, the exposed bone down here will never really make contact with the opposite articular surface. And a lot of these, what you see here, I think the damage we've got on the bottom of this bone is probably the initial damage, and what happens is that this damaged surface was working or making contact with this surface, and these are what we actually call kissing lesions, meaning that they occurred because of the damaged surface down here that was actually making contact with this surface right here. So what we'll do now is just kind of clean up these edges, make sure that we don't have anything on the far side of the joint, and that should be about it.
Dr. Mike, now that Dr. Eggleston is essentially done with the procedure, what's the next step in this surgery?
Well, the next step is to get him safely to the recovery stall. And what we'll see here, they'll take the drapes off, remove all the surgical instruments, they'll take him back to the recovery stall. And a lot of times, that's one of the most dangerous parts of the procedure. It's getting the horse to wake up and stand up and not be scared. Remember, the horse has no clue that he went to surgery. Not like us when we go to surgery. He doesn't understand that he's brought to a big university, he's going into a surgical field, and he's going to stand up and he's going to be a little bit disoriented. He's not going to know what's going on. And the thing that concerns us a lot is getting the horse to stand up quietly. And we've got this big padded recovery stall that's going to help him if he falls around, not injure himself. And he'll be laying on some big, thick 8-inch mats. Then once he wakes up completely, we'll take him back to his stall. And we'll let him stay here with us for a few days, make sure everything's fine, no infections. We'll have him on antibiotics and painkillers, and then he'll go back to the farm to make a full recovery.
Dr. Eggleston, what a great job. What a thrill. Thank you for the invite into the surgical suites. And Dr. Lauder, if you two would please just explain to the folks at home the size of these chips and kind of what we found.
Well, Ryan, what we've got here is quite a few number of chips that Dr. Eggleston has removed, some large chips that had a significant pathology in his joint. And one of the key things now that Dr. Eggleston's removed them is the post-op recovery time. Dr. Eggleston, what do you think? Where are we going to go with this horse? How long is he going to be out? When can we start riding him again?
Good question. I think based on the size of the fragment that was there, its positioning, and some of the other findings that we found as far as cartilage damage and overall pathology or disease in that joint, yeah, I think it's safe to say that this horse will probably be just hanging out, combination of stall rest, paddock, pasture time for about 4 to 6 months, and then we'll have a point of reference to as far as putting him back, a slow return to some type of work and see how things hold up. And then from there, base our other therapy, which this horse will need some maintenance type of therapy in the future, just based on.
And maintenance therapy being joint injections, systemic things to help the joint be lubricated, things of that nature?
Absolutely. A lot of the products that are out today, as far as any of the systemic legend, Adequan, and joint supplements, protectants of the cartilage he can be placed on. But this is a horse that may very well be looking at joint injections in the future just to help him out and potentially getting back to soundness.
Excellent.
That's great. Well, on behalf of the folks at HorseCity.com, I'd like to thank Dr. Eggleston and Dr. Lauder, as well as the University of Georgia and the College of Veterinary Medicine. And this has been a great special edition of HorseCity.com TV.